We're in for a very good session. And before I let Dan introduce it, I do want to say that the PDC found a paper that they found very important, and it blew my mind. And I asked Meera to go in depth on this. So Dan, why don't you introduce the next session?
Sure, thanks, Todd. So first of all, Todd, you mentioned this early on. It's amazing, this forum where we have people literally from all over the world. And I think there are people from, there are 500 people on this session who are from literally all over the planet. And all over the world, we have struggled with issues of diversity, equity, and inclusion, and the impact that has on the healthcare that we provide to the patients that we serve. Dr. Kotagal is a pediatric surgeon who is dedicated her research career to understanding global health and problems with disparities in care. And so I think it's great to have Meera come and discuss this topic with us for the next 20 minutes. Meera.
Thanks, Dan. Thanks. It's great to be here. Thanks for having me. I think this is a challenging topic. I think it's something that we're all grappling with, and as people know, has come to some resurgence in the United States over the course of the last year or 2 years, as this has become something we're talking about a lot. But I think it applies in our setting as well as lots of other settings to think about how do we provide the best care for our patients, regardless of where they're from or who they're born to, and how do we think about our colleagues and how we all work together and being inclusive. So we're going to touch a little bit on both of those topics today, but hopefully it'll be an interesting and I imagine very lively discussion. So we'll start with a case. This case is a 14-year-old Black male who presented with abdominal pain. His workup included a history, white blood cell count, and ultrasound that were consistent with appendicitis, most likely perforated appendicitis. He and his mother, who was with him at the time, report that this is their third visit to the ED over the past 7 days for abdominal pain. The patient's delay in diagnosis is due to, and here are the options, biological factors causing his presentation to be different, implicit bias amongst the providers caring for him, delay in presentation by the patient and family, or D, all of the above. So I think, while we're waiting and letting people kind of sort through the poll and answer some questions, I think, it's an interesting topic, right? We have lots of conversations about why patients may present with a delay in presentation, and this is true in appendicitis, which is obviously very common. But I think, what are people's thoughts about potential reasons that this kid might be so delayed in presentation or have shown up 3 times seeking care for abdominal pain?
Thoughts from the faculty?
I'm more concerned about the third time presentation. That makes me feel like this patient was delayed because of the providers delaying in care, not the family delaying in presentation. That's my main concern.
Thanks, Dr. Lee. Other thoughts from people?
Yeah, I'm not sure. Maybe.
Sorry, Dan.
Not sure. Maybe you're gonna talk about this, but one of the things I think that happens with people who end up coming back 3 times is that there's this concept of anchor bias, where somebody has made a decision and that everybody else then is very prone to look at it through that lens. And I think that applying the diversity, equity, inclusion lens to it really changes. It offers us a new perspective on why we think the way we do about what a patient may or may not have.
Yeah, I think it's a great point, and it extends, beyond what we might see, and particularly thinking about disparities and bias, but just to how we approach patients who have the same complaint over and over again for whatever reason, and how do we broaden the box to think about what might be going on with them. But I think there's lots of potential components there. I don't know. Should I keep? Yeah.
Well, let's see. So Ellen, what do we got?
Yeah, it looks like a lot of people are saying all of the above, and then but then half the people are saying that it is the implicit bias of the providers.
Great. So I think there's, it can sort of be, I don't know that there's always a right answer, right? I think all of these things play a role, and we'll talk about a couple of studies that I think are really important to understand the disparities that we may see. I think personally that it's probably, mostly around implicit bias. I think, to Dr. Lee's point, the fact that the patient has come in 3 times sort of suggests that the family was seeking care and not really that they were delaying trying to get care for what they thought was a concerning problem. I think the other thing, there's been a lot of data and literature out there talking about things we have historically always thought of as biologic reasons that cause patients to present differently. There are a number, people talking about hypertension in African Americans, and we've historically just said African Americans are at higher risk for hypertension, but really race is a social construct and not a biologic one, and so that genetic plausibility argument comes under attack. So I think let's talk about some of the studies that are out there and be interesting to hear what people think about them. This first study is a study that came out in pediatrics in 2020, and it looked at healthy kids. So one of the arguments around differences in postoperative complications and mortality for kids, for patients based on race was based on the fact that maybe African Americans have higher rates of comorbidities. Maybe they're at higher risk from an operative standpoint. And so this article really attempted to kind of undermine that and talk about that by looking at healthy kids. So kids with ASA 1 and 2. And they looked at over 170,000 kids across the NISQIP database and 30-day mortality, postoperative complications, and adverse events, which were cardiac arrest, sepsis. Those were the major things that they were looking at under adverse events. And they found that African American children had increased odds of all 3 in our systems. They had over 3-fold times higher rate of dying after an operation, even though they were healthy. They had an 18% greater odds of having a post-op complication and a 7% greater odds of serious adverse events. And these are otherwise healthy kids who are having routine operations within our system. So really problematic data that obviously suggests underlying challenges within our systems and the ways in which we present and care for patients. Do you want me to pause there and talk about that a little bit, or share the other article?
So let's just see what people, what are some thoughts about, this is pretty shocking. This calls attention to, you can say all you want about DEI and inequities in the workplace, but this article is so upsetting to me. And the other one probably even more, but this surprised me, and it probably shouldn't have.
I agree with you, Todd, and that's part of the problem, right? It shouldn't surprise us, but it does. And I really think that I agree with you. This is shocking data. And unfortunately, we're seeing now that the spotlight has been focused a little bit, at least in the United States, we're starting to see more and more objective data to substantiate what's been talked about for a very long time and largely ignored. Mark?
Well, yeah, I was going to say, I don't even know that it was necessarily being ignored. What's remarkable to me is that we didn't notice this, which goes to show you our own biases.
So can I tell you something interesting? This is what I thought about. I'm actually very embarrassed to admit this because it's clearly my fault. But we published a paper in JAMA in 2003. And Meera, the paper we published, our conclusion was wrong now that you're pointing this out to me. Our paper was published to say, oh, there's disparities in perforation and appendicitis. And you know what? The highest rate of perforation is in Asians. Number 1 group, Asians had the highest rate of perforation than African Americans. And our conclusion had nothing to do with, and it was never even mentioned back in 2003, 20 years ago. It wasn't even mentioned that could there have been implicit bias related to this. It was all, oh, maybe it's genetic, maybe it's resistance to care, blaming the patient rather than in any way introspectively saying, I bet you if we did this paper again in 2023, we would find the same results, but with implicit bias being the reason.
That's a great point, Todd. I'm curious. There's some conversations going on in the chat, and I know Al is Stanford. Dr. Stanford's done a lot of work in this area, is contributing there. Thank you. I'm curious if any of the other folks from around the world have similar problems in their country. It may be different cultures or different ethnic groups that might be treated differently or have different outcomes. But is anyone else looking at this in other countries as well? I'd love to see in the chat as you go on.
I think it's a great point, Dr. Wolkin, and as Dr. Von Allman mentioned, I spend a chunk of my time working in resource limited settings, and I think, you know, there's a really striking example. There was a paper published looking at gastroschisis mortality and thinking about gastroschisis mortality around the world. It was led by Naomi Wright.
I clicked on the OK button, but I'll do it again.
Mac, I think you're unmuted.
Led by Naomi Wright, and it was a great study and really, you know, highlighted the difference in gastroschisis mortality across the world. So when we think about gastroschisis in the United States and our patient population, because of TPN, because of NICUs, because of the resources that we have, right, our mortality rate is, you know, close to zero, if not quite in zero. But, you know, in many resource limited settings, particularly because of the unavailability of TPN, but also because of social concerns around diagnoses such as gastroschisis, the mortality rate used to be close to 100%. And there have been significant efforts to reduce that, but there's lots of disparities that show up in that way too, based on resources and access to care. And I think Dr. Stanford's talking also about access to care in the US, right? Insurance and the ways in which it allows you to present, who can you present to, how seriously are you taken? And Dr. Grant talking about, you know, the ways in which we think about Black patients. And there's lots of articles about pain thresholds, you know, particularly in the ED literature around treatment of pain in patients with appendicitis, amongst other, you know, etiologies, and whether or not we treat pain equally in patient populations. Okay, well, let's move on to the other study, which, as Dr. Bonsky said, is additionally concerning, but also tells us something about what might be underlying what we see. And this is a study that was also published in 2020, and it looked at concordance between physicians and patients and really understanding infant mortality. So, you know, it centers on the fact that we see wide disparities in infant mortality between Black and non-Black patients in the United States. And this study looked across Florida between 1992 and 2015 at 1.8 million births, and looked at the concordance between the physician race and the race of the newborn that was born, and found that Black newborns have a 58% reduction in their mortality if they're treated by Black physicians. So looking at the same percentage, you know, same populations of newborns, you see a huge difference in mortality rates between Black and white infants, but that you can make a dent in that mortality rate for Black infants by treating them with Black physicians. And I think this is important for a lot of reasons. It points at implicit bias in the ways in which we approach our patients and think about our patients, but it also points at the importance of diversity in our systems, and that by having, you know, patients who look like their providers who look like their patients, you have an opportunity to really allow people to see and understand people who are different than we are. Todd, you mentioned that this was particularly shocking. Tell me.
We have to just stop. We have to stop for 1 second. I mean, we just have to stop because there's been a lot of information given to us today. We've learned, I mean, it's very rapid fire. The update course is very frenetic. There's a ton of content coming in. We need to stop for a second. This is the most upsetting paper. And, you know, for Stephen and Marge and Rob, when you brought this article to the PDC, I don't know if I'm allowed to like bring it out, but I hope I am, because I thought this is horrible against us as clinicians. I mean, what does this say about, I mean, so we're isn't educated. I mean, it has nothing to do, we're in diverse cultures. Still, this is happening. This is very alarming. This is a point to stop and say, what the heck is going on here?
It's not just the birthing mortalities, but I mean the moms, right? Between Black and white moms in the United States, at least the mortality is over 300%. It's more. And these are young Black women. I mean, you guys know that I'm slightly involved in social media. I mean, I see women residents who are close to, who live in a health institution who has the ability to seek care, prenatal care, and they're still dying. We need to. I agree with you, Todd. It's upsetting. The fact that the mortality of infants from Black mothers is high. It's probably because a continuation of whatever is going on in the physiology while they're in utero. Higher prematurity rates, and it needs to be highlighted, and we need to start thinking about it. And part of it too, in terms of what Dr. Kotagal has said with regards to implicit biases, et cetera, I mean, that's kind of one of that points with the family-centered care that we talked about before. Validate their concerns, and listen to what the patients are saying, and their parents and their caregivers and whomever it is that brought them there, and not say it's just constipation. They look weird, they smell funny, they smell like pot, all these things. You just need to kind of say, this is my patient, what's going on?
Thanks, Dr. Todd, can I point towards Dr. Garcia? Because I think, as we're talking about the physiology, right, and the things that we're seeing, the ways in the context, all of those pieces, I know this is work that Dr. Garcia spent his life working on and thinking about, and I would love to hear his comments if he has any.
I mean, I do. I mean, I think, one of the things, this is not new. This has been available information for decades. And 20 years ago, Collins from Chicago just demonstrated that a highly educated Black woman, lawyer, will have a higher risk of dying in childbirth than a white woman with just about a high school education. We have a clearer understanding of some of the underlying mechanisms, and I put in the chat about toxic stress and allostatic load, Bruce McEwen's work. I urge you all to look at the biological embedding of adverse early childhood experiences, the Sackler colloquium that was done that really highlighted the basic neurobiological mechanisms that have contributed to not only what we're seeing now, but also outcomes as far as educational and economic attainment. So there is an underlying neurobiological embedding of toxic stress that is particularly spatially located. I mean, certain neighborhoods, and it's not just unique to Blacks. Sir Michael Marmot in his early work demonstrated that classes of individuals who are gainfully employed in the national health system actually had higher mortality rates the lower they were on the socioeconomic ladder. So does that help, Meera?
Of course, and I think Dr. Garcia, when you walk away from conversations with him, you usually get a reading list, and so I think he's shared some great resources. But perhaps, Vic, you could put a couple of them in the chat for people as well, so that they could look up what you're talking about. I think the ACEs paper that we tend to come back to a lot. The work of Rob Sampson, those things that really are central to understanding the impact of neighborhoods and context, and on epigenetics and other things that we see for our African-American patients, and the fact that what happens in their first month of their life impacts, their neural development and all of those pieces. And so I think there's a lot there. There's some great conversation in the chat, I think, about thinking about how we make an impact there, right? How we, some great questions about how do we improve diversity? How do we change the systems? And Dr. Stanford's chiming in with some fantastic suggestions about institutions and about representation and the ways in which those things matter. We had planned to touch a little bit on sort of DEI within institutions, but I don't want to cut this conversation short. So I wanted to sort of.
Here's what, so I was going to answer your direct message to me, Meera. This is your session. You know how to get this done effectively, and I'll open this up to anyone to figure it out. We've got 10 minutes left to make a difference. So, Vic is saying if this has been around for so long, obviously it's been around for so long, finally, as we've learned from this idea of repeated information to people, not just at one conference, but at 10 conferences a year until things start actually changing. I'm willing to wager a bet, and this is very cynical of me, that if you repeat this study in 10 years, it's going to look the same. So tell me how it won't. Like we can, I can't figure, how do you, the fact that a child's race that child will get better care from someone of their same ethnicity than someone of a different ethnicity is astonishing. And I have no idea why we think that won't change again in a decade from now.
And Meera, correct me if I'm wrong, but I think that in that paper, it's not even the child's doctor, it's the obstetrician that delivered them, right? So it's the prenatal care that is.
It is, though, interestingly, the concordance between the prenatal care, between that obstetrician and mom did not have an impact on maternal mortality. So it seemed to have an impact on neonatal mortality, but not maternal mortality in that paper, which I think is interesting, but not worth getting into the weeds about. I think Todd makes a great point about what do we do, right? What are the ways in which—
So what have you done? And tell us, because I will tell you, I don't like going to conferences very much. I have ADD. You guys all know that. But Meera, the one you ran was really well done. And I know that when we went on Clubhouse, I was critiqued for saying that we're doing conferences on this, and there's no way you can teach them, stop the conferences. You'll never be able to teach them. The thing you did was impactful. So what are you doing, and what are others doing in their hospital that's not just a check the box, but actually going to make an impact?
So I guess I have a couple of things that I can throw out there for people to think about, and I'm sure others have comments. I think, I think all these pieces tie together. We talk about representation, and I think that matters. How we think about diversity, equity, and inclusion within our own institutions matters, and it has to start at an early age. Pipeline programs can't start when folks are in college. They need to go back quite a ways and be able to provide opportunities to folks early. So I think there's some areas to think about with that, and we're not going to get to these articles, but I think really recognizing that there are disparities that continue. You can bring females to medical school, but you might not necessarily get them to full professor level, right? All the ways in which those disparities exist. So I think the representation piece matters. I think thinking about how we treat people within our systems, and that's what Todd's referring to. The University of Michigan, and some really great work out of there creating the cultural complications curriculum, which I think a lot of people have heard about. But if you go to culturalcomplications.com, there's a great website that allows people to really start within surgical departments talking about these issues. And we've started doing this within our department, led by Dan, to really grapple with these issues and have honest conversations about cases that maybe do make us uncomfortable, but to approach them in a way that is sort of similar to M&M and into a format that we know about. But let's talk about issues of bias. Let's talk about the ways in which gender schemas affect how we evaluate people, right? All of those things that play a role. And then the last thing that I would say is that what we do within the walls of the hospital is probably not enough. And so I think really thinking about how we have an impact early. And, Dr. Garcia often quotes to those of us who work here at Cincinnati Children's that if you live in the neighborhood right around Cincinnati Children's and you don't leave by the time you're 10, the profound effects on your life expectancy and your life trajectory, and the ways that we've tried to solve those problems historically haven't worked. And so I think there's some great work around social innovation labs and recognizing the complexity of the problems and the need to really address poverty and context at its roots, and discussions around social determinants of health. I think, we're spending a lot of time in neighborhoods working on how do we get at the root drivers of these problems and not just try to put Band-Aids on them when people are within our walls, but really start to address them from day one, right? From prenatally, even if you look at some of these studies and thinking about how we have an impact. So those are just some thoughts from me, but I'm sure others have thoughts as well.
I think, Meera, you summed it up well. And the problem is the degree to which this problem has been sort of woven into the fabric of our society. And I think that we can do things locally. And so we can start with a microcosm of a department or an institution and begin to work on these things. The next level is to start doing things like working on pipeline. And the most complex, in my mind, and Vic is the expert on this, is beginning to address those things that are beyond the walls of the institution, like the social determinants of health. But we should not and cannot abdicate some responsibility for addressing those things.
And I think to a really important point that's being made in the chat, but I think is that we can't do those things in isolation of the communities we serve. And that if we're really wanting to grapple with these issues at the community level, we have to do so in partnership, in solidarity with those voices at the table, really seeking and asking to understand what the problems are from their perspective, because we can come in with a lot of assumptions about what we think makes a difference, but understanding how the community feels about it in individuals within those communities is really central.
Can I just give one quick example, Meera? So I don't get much out of lectures. I don't pay attention. But first of all, I can come to you as a white male and ask you a question, and you answer me and I don't feel nervous to ask you, hey, am I an idiot for asking you this question? Is this a microaggression? What's the best way to say this? And the one example of the way you did it, where you presented these cases, we had these breakouts, we talked about it, is that I did not know about microaggressions until you taught me about it. And every one of them were things I can clearly see I would have kept doing without someone pointing out to me those were microaggressions. And I'll like, oh yeah, I never would have realized it. And there's I think those
Dr.
things help.
Ponsky, if you go to a level 1 trauma resuscitation with your mask and your PPE, and you start barking orders, people actually think you're the surgeon who's taking care of these children. Now, having come to another institution where I wasn't known, I was told by an ortho resident that, don't I know that when people lose blood from a femur fracture, it's not just red cells that they lose, that I may be needing to think about plasma. And I looked at him and I was like, yes, I guess you're right. And these are the things that Dr. Kotagal and I deal with daily. We're who's your attending, or, oh, the nurse just walked in. And you're like, yeah, okay. I'm actually their boss, but that's okay. I mean, where we would have these conversations where we have trainees, white male, tall trainees, and we talk and parents look at them for confirmation. It's our life.
I think it's really important. And I think one of the things I really appreciate, Todd, about the ways in which you raise and guide these conversations is also the really important role of upstanders. And, we've talked about that a lot in our context, which is you can't be bystanders, you have to be upstanders. And for people like Dr. Arka and myself, we can advocate and raise our voice and try to say, let me point out to you that I think there's a microaggression there, or let me point out to you the ways in which you're making assumptions in that conversation, but having, for better or for worse, your voice has power, right? The voice of Dr. Von Allman has power, and being able to say that those are voices that are raised to also raise those concerns, right? To also speak up, and that upstander role is really important.
I think we've got 2 minutes left. I know you didn't go through the slides you were going to, because this was obviously such an energetic discussion. What comments do people have? I mean, Mark, I love your point about international. We're talking about, we're focusing on United States here. What about, the rest of the world? What other comments do people want to make in the last 2 minutes? And if not, Meera, what can you drive this home with?
Ronnie looks like she wants to say something.
I just want to comment like one small thing, because I think that this problem is so huge and there's so many aspects of improvement that we can do as a society, that we can do as a government, that we can do as a community outside of the hospital. I think when people are not involved in DEI or not involved in the policy making, the one thing that you can do is sort of look inside yourself as well, not to put the onus on each individual, but it is important. Go to the Harvard website, take the implicit association test. There's like so many of them that you can take, and you could think about, you could take the racial one, you can take, there's an obesity one, there's a disability one, there are so many, and you can take these tests and do it in the privacy of your home, maybe with a glass of wine, because it's heavy. And to look at yourself and to say, what am I doing and what can I do better? And what I have to be aware of my own implicit biases, because that's the whole reason that they're implicit. We don't know that we're doing them until you discover, or until somebody has, you know, the wherewithal to tell you that you're doing something wrong. And that's obviously not the only answer, because we still have to make sure that we are reaching out to the pipelines in our communities that are underprivileged, and making sure that we are standardizing our interview protocol and our promotion protocols and everything like that, making sure that people are trained to appropriately assess somebody without bias. It's impossible to completely be without bias, but the first thing you can do if you're looking for something to do is to go to the Harvard website and take the implicit association tests. I'm going to put it in the chat just so people know where it is, but it's important.
Hey, Todd, in Chile, all male doctors from intern level onwards are called Dr. something, and all female doctors, no matter how senior they are, they're called señorita. And I don't think I have to translate what señorita means.
Wow.
It's really difficult. I think Dr. R can mention it, but it's really serious here.
But can I ask you a quick question? Is stuff like, is this getting recognized, or is it way behind in this being a priority issue of changing?
I think it's getting in our heads. It's getting into discussion. We are in Chile. We're changing from a predominantly male-based senior surgeons, and actually most of the trainees are now female. So we are in a transition model, and we're, I think, getting more responsible about this implicit bias. Also in other conditions, not only female, male, but indigenous people get worse outcome. I think that's already been measured here, and they come late and they get delayed treatment, and it hasn't been measured, but we all have the feeling that, for instance, appendicitis in the public hospital, we have much higher rates of perforation and peritonitis than in the private hospital. And that hasn't been measured, but I think anyone here would agree that that's a reality.
Well, I think this has been a very provocative session. We're running over. Again, and I'll let Dan close it home, or Meera and Dan close it, but it's not just that we're talking about implicit bias here. We're not talking about DEI here. We're talking about the reason this was shocking to me is it's not employee to employee. This is our patients are getting different care from us based on what their race or ethnicity is. That should alarm us to the highest degree. Meera, Dan, final comments?
I think I would just say, I think there's a lot out there right now. There's a lot of discussion around disparities and you know, people thinking about these issues. I think there's sort of two things that I would push on people to. One is exactly what Dr. Solins is talking about, which is really recognizing that we all have biases and really trying to understand them for ourselves, and not being defensive when someone says there's bias in that, because we all have bias. We know that we all have bias. And so the question is, what are your biases and how do they affect what you do? The second thing is that there's been some discussion around what people are calling, you know, the health disparities industrial complex, which is there are 1 million papers written about health disparities. And so I would push everyone to say, as you're thinking about this work, as you live in this space, you know, what are you doing about it? So let's not just settle to talk about it, but let's figure out what the system level changes are that make a difference and change the outcome.
That's great, Meera. Thank you. And thank you for raising this issue. Obviously, we could spend, and at some point should spend, days talking about this stuff. But I think that, you know, it can be so overwhelming when you think about how many tentacles there are and how complex it is. But I think the worst thing we can do is nothing. So do something. We'll make mistakes, but do something.
Todd, if I may, I'd hate to end the presentation on a down note. I just wanted to recognize a colleague and a friend, Dr. Andrea Hayes, who was just named a chair of surgery at Howard University. And we as pediatric surgeons should celebrate that. There are not very many chairs of surgery or pediatric surgeons. And Dr. Hayes is the first woman Black surgeon. And I'm just so happy for her, and so happy for what that choice represents. So just wanted to let everyone know about that.
I'm glad you mentioned that. And considering she was one of the first people that ever trained me, I've been seeing it all over social media, and it is a very, very important step in our history. So, okay. Thank you, everyone.